And good afternoon, first 3 years attendees for our webinar this afternoon. If you can hear my voice coming through your computer, please type a yes in the chat box in the bottom right-hand corner. Thank you, Sue. Thanks, Michelle. Great, Beverly. Awesome. Hi, Smithy. Good to see you here virtually. Wonderful. Thanks, everyone. Well, thanks for joining us. For our webinar this month in January, we're talking about prevention. The topic for today is the prevention of sudden infant death syndrome, the prevention of shaken baby syndrome, and the prevention of child abuse. And so that's a lot of content to pack into just a quick 60-minute webinar online for you. However, we are going to hit on all of these topics and talk about risk factors, things to look for, indicators, and then also, most importantly, those prevention indicators and how we can help to create the safest environments for our youngest Texans. The January webinar is sponsored by PNC Grow Up Great. PNC is an organization that helps children from birth through age 5 develop a passion for learning that lasts a lifetime and can help set them on a path to success. And actually, PNC has sponsored several of our webinars for the entire year, so you will see that in the content that we have listed for our webpage for the webinar series. And so we are committed, along with PNC, for this year to focus on school readiness. And so we are building in the theme of school readiness with all of our topics for the webinar series for 2018. Like I said, the topic for today is prevention, SIDS, shaken baby syndrome, and child abuse. So sudden infant death syndrome, the acronym there is SIDS, and then the acronym for shaken baby syndrome, a lot of times that you'll see is SBS. So if you're not familiar with those, sometimes that's how those syndromes are referred to in the community. The very first thing we're going to do is we're going to talk about prevention, and we're going to discuss the angle of the topic for today is all about prevention. And so we're going to talk about the differences between SIDS, shaken baby syndrome, and child abuse, and the definition of each one of those things, and look at it from a lens of how do we work in all of the work that we do directly with young children and with families to create safe environments for infants and toddlers, and the safest environments for families as an entire unit. We're going to talk about the definition of sudden infant death syndrome and what it is, and the difference between sudden infant death syndrome and suffocation. A lot of times people in the community will get these two diagnoses mixed up or think about them in the same way. One of the reasons for that is because the prevention efforts for both are very similar. And so a lot of times people become confused and they think that sudden infant death syndrome and suffocation are the same thing, and in fact they're not. So we're going to spend a little bit of time looking at the difference there between those two. We will talk about the ages at which infants are at highest risk for sudden infant death syndrome in an effort to recognize the greatest prevention efforts and how and when to be most mindful of it, and then also the overall definition. You will be able to define what a safe sleep environment for babies looks like. And then we're going to move into understanding the risks for child abuse and potential indicators, and then the prevention efforts for that. And then also we'll look at the definition of shaken baby syndrome and the prevention efforts for that as well. And then finally, at the very end, I'm going to allow time for you to identify a couple of ways that you can share this information with parents and practitioners. So the idea is that you are on here for this 1-hour discussion for a refresher of information. Perhaps you'll learn some new information, but then overall at the end of the hour, thinking about how can you help to disseminate this information. As professionals in this work, we do have a responsibility to not only learn about the best practices to keep babies and families safe, but then also to share that information with other people. And so that is with your colleagues, with the families that you work with, and just people in general in the communities, as it strengthens our community to help keep children safe. The definition of prevention is exactly what this image looks like here, which is this hand right in the middle of these stack of dominoes that are tumbling down from the north. And it's the action of stopping something from happening or arising, the act of preventing or effectual hindrance. So intentionally causing a stop to something, creating an intervention, providing that hand in the middle or brakes on the tracks, whatever it might be, to prevent something from happening. As we look at the definition of the three topics that we're talking about today, like I said, we're looking at this from a lens of prevention. So these three categories, sudden infant death syndrome, shaken baby syndrome, and child abuse, are not all necessarily the same thing. Shaken baby syndrome is definitely caused by a form of physical child abuse. However, don't be confused that sudden infant death syndrome, because it's not related to child abuse. As the definition, as you can see here, of sudden infant death syndrome, also known as SIDS, is the unexplained death, usually during sleep, of a baby less than 1 year old. And it appears to be associated with defects in the portion of the baby's brain that controls breathing and arousal from sleep. And that is not child abuse. If a baby dies from child abuse, then the cause of death is defined as child abuse or shaken baby syndrome. So I just want to make it clear that the definition of these three categories, we're looking at this from the topic of prevention today and what are our prevention efforts on these three topics, but these categories are not all necessarily related or caused by one or the other, although we do see some of that happening between child abuse and shaken baby syndrome. Shaken baby syndrome, also known as SBS, is abusive head trauma, and it's a serious brain injury resulting from forcefully shaking an infant or toddler. And this is aggressive shaking, abusive shaking. Typically, the baby's being held by the shoulders, and it's violent. It's violent shaking of a baby. It's not, SBS is not caused by you bouncing a 9-month-old baby on your knee. That's not how babies get brain injury. This is a violent shaking back and forth where the head is rocking back and forth on top of the body like a bowling ball. And so if you were to see a person shaking a baby violently to where the baby might have shaken baby syndrome, it would be evident. It's not this, I'm playing with my baby, I'm just tossing them up in the air sort of idea. And then child abuse is any intentional harm or mistreatment to a child under the age of 18. And we've got several different categories under child abuse that fall in there. And so we're going to be looking at prevention on all three of these topics in the next few minutes. Sudden infant death syndrome, one more time to define it, because this is a really hard concept to understand. It's the death of an infant under 12 months of age. And the death in and of itself cannot be explained. So there's a thorough investigation, including a complete medical autopsy, examination of the death scene, and a review of clinical history, and there is no explanation for why the baby died. If there was an explanation for why the baby died, then that explanation would be the cause of death. Sudden infant death syndrome is defined as the cause of death when there cannot be any other explanation. So what that means is this diagnosis is a diagnosis of exclusion. It means the clinical autopsy excluded anything else that we know that would have caused the death of this baby. And so it's an unexplained death. And it's a really hard concept for us to understand because we always want to be able to determine the cause, right? So we want to know what happened. And in the case of SIDS, it's simply unexplainable. And that's why the SIDS diagnosis becomes the diagnosis there. So for the prevalence of SIDS that we see, it's about 1,500 infants who died in 2014 of sudden infant death syndrome. And we do know that the prevalence of SIDS is declining. So you can see the Back to Sleep campaign has worked in many communities, and infants who are placed on their back to sleep in basically a dry crib, which means there's nothing on that crib sheet except the fitted sheet, that is working. That has helped to protect a lot of babies and keep a lot of babies alive and thriving and sleeping well through that first year of life. And after 12 months, we do not have SIDS diagnoses for babies. SIDS is the leading cause of death in infants from 1 to 12 months old, and it's not the same as death by suffocation. So as I already mentioned, it's the unexplained death of an infant. If an infant dies from suffocation, then the cause of death is listed on the death certificate as suffocation. We know if a baby suffocated, we know that they suffocated and that's why they died. And that's not the same as SIDS. Infants are at highest risk for SIDS between the ages of 1 and 4 months. Now, any baby under the age of 12 months can die of SIDS, or can, die and it be explained as a SIDS, which is this unexplainable sort of diagnosis. But we see the highest risk area being between 1 and 4 months. So once again, it's the unexplained death, and it means that's the diagnosis of exclusion. And some factors we do know can increase the risk. And so what the latest medical model for sudden infant death syndrome, the theory that's coming out is that there are some neural connections in the brain that are immature. And the neural connections that are responsible for the autonomic response that tells my body to keep breathing while I sleep, that they're just not strong enough and developed enough for that little baby's body to continue to breathe when the baby goes to sleep or falls into a deep sleep. This is theoretical model, but with medical advance and medical technology, this is kind of where we see the medical model going in the best explanation for sudden infant death syndrome. And so some of that is defined by brain defects. So the portion of the brain that controls breathing and arousal from sleep is immature and still growing. And so, in that moment that baby is sleeping, that neural connection doesn't fire, the autonomic response doesn't tell the body, breathe, the lungs don't intake oxygen, and so then the baby dies. Low birth weight also increases the likelihood that the brain hasn't matured completely. And so then you might see that the autonomic responses, such as breathing and heart rate, may not be fully developed. Respiratory infection can be a complication that places an infant at higher risk. And many babies who die of SIDS recently had a cold, which may contribute to breathing problems. We also see sleeping on the baby's stomach or their side, or sleeping on a soft sleep surface, or sharing a bed can also be related to increased risk. And then finally, overheating. So being too warm while the baby is sleeping can increase risk. There was some data collected in areas where the climate is a little colder, and parents, bundle their children up in a lot of different layers to transport them from home to childcare or grandma's house, wherever they're going for the day. And when they get there, if they do not unbundle their children, right, they leave them dressed up in all these layers, even though now the baby is in a heated room. That the baby's body can become too warm and overheat. And the baby isn't dying from overheating, because if the baby was dying from overheating, that would be the cause of death. But that when that body gets so warm, once again, the autonomic response doesn't respond for whatever reason, if it's a defect in the brain or immature neural connection in the brain, or for whatever that cause is. But the overheating also seems to be related to an increased prevalence of sudden infant death syndrome in those areas. And so it's important to think about that if you are transporting your very young baby, or if you're talking with parents who, are moving kids and they've got to layer them up to get from one place to another, that when they land at that destination, that they should, bring the baby back to a clothing that's appropriate for whatever that climate is inside once they get there. And that would be, by and large, we typically say babies are going to be comfortable dressed in whatever you as the adult would be comfortable in. Additional risk factors include gender. Boys are slightly more likely to die of SIDS. So, when we look at the data, we see that more boys have died of SIDS than girls. Again, not really sure what's going on there or why. And then the age, we'll just say that one more time. Infants age 1 to 4 months are most vulnerable. So we see the highest concentration of SIDS deaths happening at this age. Race, for reasons unknown, non-white infants are at higher risk. Again, medical technology is trying to get at the root of this and see if there are any genetic risk factors there. And there are a lot of theories out right now, but again, it's still a diagnosis of exclusion, which means we don't really have, a cause for this. And family history. Babies who've had other children in the family die of SIDS are at higher risk, but that does not mean that SIDS is contagious. So that's a very different message. SIDS is absolutely not contagious. However, if we do think that there is some sort of genetic factor for an increased risk of SIDS, then it would make sense that if there has been a baby who's died in the family, that another baby may be at a higher risk. Secondhand smoke disrupts the respiratory system growth and development. And so we know that babies who live with smokers are also at higher risk. So one thing to remember about secondhand smoke is that it is transdermal. So it lives in your skin and it lives on the clothes that you wear. And so when I worked at Nexus Recovery Center, many of our clients who were in the drug treatment program there, who had newborn babies, they continued to smoke, and that was addiction they would try to also work on, but may still be smoking right after they had their babies. And so we would work with them to understand that when you go out for your cigarette, when you're done, come back in, wash your hands and face, and change your shirt before you pick your baby back up, because that secondhand smoke not only lives in my shirt, but it also lives in my skin. So it's on my face and it's on my hands. And so if I'm washing, all of that, then I'm reducing that exposure for my newborn baby. Premature babies are also at risk because, again, we might see low birth weight, we might see that prematurity, and again, the autonomic system, of the baby is just already at a greater disadvantage at that point, and so they're at higher risk for SIDS. Okay, this was a safe sleep PSA that was produced by the American Academy of Pediatrics in 2016. And this is actually a pediatrician who lost a child of SIDS.
Each year in the United States, approximately 3,500 infants die from sleep-related deaths. In hopes of reducing that number, the American Academy of Pediatrics has just released its latest safe sleep recommendations.
The safest place for the baby to sleep is in a crib or a bassinet or a playpen, something that's separate from where the parent is sleeping. And the only thing that should be in the crib should be a tight-fitting mattress with a tight-fitting sheet and the baby, nothing else. There should be no bumper pads, no pillows, no blankets, no stuffed animals, just the crib, the mattress, and the baby.
Dr. Sam and Maura Hankey know too well the tragedy of losing a baby to sudden infant death syndrome, or SIDS, when 6 years ago Sam and their newborn son Charlie were napping together on the sofa.
The one time he wasn't in his crib was that horrible night.
The risk of SIDS is 5 times higher if a baby is placed on any soft or squishy surface such as couches, pillows, or blankets. Doing so can create an air pocket, making it difficult for the baby to breathe. Bed sharing also increases the chance of SIDS.
We know that bringing the baby into bed with you, surrounding the baby with soft bedding so the baby doesn't fall onto a hard surface, all of these things that parents think are going to keep their baby safe, in reality make it more dangerous for their baby.
The image of putting a baby to sleep in an empty crib, I think, feels cold and harsh. In reality, it's very safe. It's the best thing that you can do for your baby.
As a parent and as a pediatrician, I did what I thought was best for my child. I didn't think that SIDS could happen to me, but it did happen to me, and it can happen to anyone. And that is why it's so important to follow these recommendations for each and every sleep, at nap time and at nighttime.
I'm Jack Trammell.
So we're going to talk about the latest recommendations from the AAP for safe sleep. And this was published in October of 2016. And the latest recommendations to protect against SIDS include placing the baby on his or her back on a firm sleep surface, just as you saw in the video, with a tight-fitting sheet, and that's it. So, not the bumpers and the blankets and all the cute matchy things that you want to register for at Babies R Us or Bye Bye Baby and have given to you at your baby shower because you've got this beautiful nursery and everything matches. Really, the best, safest sleep environment is that crib is bare. There's nothing in there except for a fitted sheet. And as a matter of fact, the baby should be sleeping in only what the baby is dressed in. And so if it's colder outside, then you buy a onesie with a footie in it that zips up the front, or they're clothed in what they're sleeping in. There's not an additional blanket on top. The second latest recommendation is that the baby's crib and the baby in the crib shares a bedroom with parents, but not the same sleep surface. And that's important to look at. One of the things that we started looking at the end of last year when this recommendation came out, actually at the very end of 2016 and as we went into 2017, was how do we communicate with parents this latest recommendation and make sure that it's clear to parents what the recommendation is, because many parents may see this recommendation and think that the recommendation is for co-sleeping. And as a matter of fact, co-sleeping is different than room sharing. So room sharing is that crib, that same crib that you just saw, is in the same room as the parents, preferably until the baby turns 1, but at least for the first 6 months. But that does not mean that the baby is sharing the same bed as the parents or with anyone else. And so what they found was that room sharing decreases the risk of SIDS by as much as 50%. And then finally, again, and this has been a long-standing recommendation, is avoiding the baby's exposure to smoke, alcohol, and illicit drugs. Additional recommendations include skin-to-skin care, so sort of that kangaroo care, particularly if you have a low birth weight infant or a premature infant, to help with the system growing and that autonomic response and the neural connection and all of the things that happen, like we see going on in this picture. However, I just want to point out this is a beautiful image of kangaroo care, skin-to-skin care. However, we would not want to recommend that the baby would be sleeping in this position, because the baby is not on his back. The baby's on his stomach in this image. And he's also not in a bear crib like what you saw in the video. And so this would be a time of where the baby is awake or alert or just calm, right? And we know the baby's still not going into that full-on deep sleep mode. And as the baby goes to sleep, then you would take the baby from this position and lie them on their back in a bear crib. Breastfeeding is a protective factor for a variety of things, but including sudden infant death syndrome. To offer a pacifier at nap time and at bedtime, again, that idea is that if the baby has a pacifier in their mouth and they're doing this sucking and swallowing rhythm, that they're going to be stimulated to a point to where the autonomic response that says breathe is continuing to be stimulated, and it says, oh yeah, breathe, oh yeah, breathe, rather than to where the system just stops responding because that baby's body is immature and went too far into too deep of a sleep, and so the body didn't breathe. So there are a number of products on the market. If you have been to a baby store recently or been to a baby shower recently, maybe you saw this when you went to shop, that market themselves as SIDS prevention devices. So sometimes these look like bed positioners or wedges, or even these monitors. And so the idea here is that there's a monitor that you can put on the baby's mattress underneath that fitted crib sheet, and that it senses all of the baby's intricate movements, and so that monitor will alert you if the baby hasn't moved in like 10 seconds. I don't know, I'm making that up. I haven't really looked into these monitors, but what I do know is that the American Academy of Pediatrics recommends that you do not use them, and that they're not prevention efforts. They really don't help with anything. So one of the things about the monitors that I will point out is that being alerted that your baby hasn't moved in a certain number of seconds actually causes more stress for parents. And additionally, if a baby has a SIDS episode, the baby cannot be revived. So it's not the same as cardiac arrest where, I'm being alerted that my baby hasn't moved, right? Or, if my baby is in distress at some point, right? If you go in there and the baby has a SIDS episode, the baby cannot be revived. You can't apply CPR and bring that baby back to life like you would if there was a person that had cardiac arrest. And, we've got that technique of CPR to help that person live until medical help can get there. And so again, SIDS is not cardiac arrest. If a baby was dying of heart problems, then we would be able to diagnose it as heart problems. And so it's important to recognize that SIDS is not, you're not able to respond and bring a baby back from a SIDS episode like you might if there was something going on with the heart. Infants should receive all recommended vaccinations to protect against SIDS and keep their bodies healthy and growing and thriving. And then supervised awake tummy time, again, tends to be a protective factor to facilitate development overall. And so while the baby is awake, if we're providing tummy time, then again, we're strengthening those neural connections. We're strengthening the muscle control around all of these major organs, involuntary organs in the body that keep all those systems running, even when I'm asleep. And so promoting development on a preventative side also helps to reduce the risk of SIDS. It is not, I'm just going to touch on these points one more time. SIDS is not the same as suffocation. It's not caused by suffocation. It's not caused by vaccinations, immunizations, or shots. It's not contagious, not the result of child abuse or neglect, not caused by cribs, not caused by vomiting or choking, and also not completely preventable, but there are ways to reduce the risk. When the Back to Sleep campaign launched several decades ago, there was a large body of people who responded saying that they thought that if the baby was placed on their back to sleep, that the baby would die of vomiting or choking because, little baby digestive systems are also not completely developed, and they're still forming and growing, and babies spit up a lot. However, there was no increase of death by vomiting or choking through the many years that the Back to Sleep campaign has been advocating for SIDS prevention. And so that is a myth to think that the baby will vomit or choke. They actually, their neck muscles are strong enough as young babies to be able to clear that out. And so placing babies on the back to sleep is still the best practice. You want to protect the baby's airway and the breathing. So you can see this baby here has a flat, neck. If we were to look at the back of his spine, you could see that his neck was flat there. One of the things that Dr. Middlemiss will touch on in the expert session for this topic that we have this Thursday is that you don't want the neck to be in a supine position. And what that means is where the neck is curved forward. So just imagine a baby in a child seat, like a car seat, right? Carrier, infant car seat carriers. They're kind of curved, and where that neck is crunched forward and maybe the chin is even almost touching the chest, that would be called a supine neck, and that is a risk factor for SIDS because there's not a clear airway there. So you want to make sure that there's a flat neck, a clear airway, kind of a straight line there on the back side of the body. Protecting the arousal response, and that's one of the reasons for the recommendation that the crib is in the room with a parent. That room sharing idea is that there's another person sleeping in there. That person might be making noise, moving around, and so that stimulation through the auditory response is keeping the baby in a more alert state than falling into a very, very deep sleep where they might be in a completely silent room, no airway circulation, and then again that autonomic response fails because the part of the brain responsible for it isn't completely mature. Another recommendation is to have a fan on in the room because, again, it's circulating air. When the wind hits my face, I'm a baby. I feel that stimulation. That sensory part of my brain says, oh, yeah, breathe. Again, theoretical model here, but this is the closest that we're looking at in the ways of prevention. Protecting the baby's temperature and, again, avoiding overheating. I'm going to share with you just a part of this video. It's a 7-minute long video, so I'm not going to show the whole thing. However, it's less clinical than the last video. The last video was a great little commercial, right, as a reminder for us to think about. But this is a video that you could share with the parents that you work with. It's spoken in very generic terms that everyone can understand. It's got some nice, cute music in the back, and it's got some real simple ways to remember the best way to sleep. So I'm just going to show you the first few minutes of it so you can get the sense for this video.
Nothing is more important than keeping your baby safe. Babies can spend as many as 16 hours a day sleeping. As a parent or caregiver, it is important to sleeping. As a parent or caregiver, it is sleeping. Nothing is more important than keeping your baby safe. Babies can spend as many as 16 hours a day sleeping. As a parent or caregiver, it is important to be sure
Well, I'm not sure why the video isn't loading. I apologize for that. It played perfectly last Thursday in the first general session. That's okay. I was just going to show you the first couple minutes anyway, but you could hear the music in the back, and that soft, gentle voice that parents can understand, right? Not only understand, but that is just calming and soothing. This is a sensitive topic. In that first commercial, the public service advertisement, it is kind of hard to watch Dr. Hankey at the end, right? You can tell that he's kind of scripted. It was probably a very difficult PSA for him to make, having this be such a personal issue to him. And I mean, he's lost a baby, right? So very emotional. And so this could be a really hard topic to have a conversation with parents about. And so this short video from the New York State Office of Children and Family Services is sort of it presents the information in a really gentle way and in a way that parents can remember. So it's public, it's on YouTube. I will share the direct link with you when I send out the follow-up email later this afternoon. So moving on to child abuse, we've got 4 categories listed here for child abuse. So you have physical abuse, everybody knows what that is, neglect, failure of a parent or guardian or other caregiver to provide for a child's basic needs, sexual abuse, activities by a parent or caregiver such as fondling, we know what that is, right? It includes the range, right? Not just having sex with a child, but includes the range of the list that we see here. For children, and then emotional abuse, which is a pattern of behavior that impairs a child's emotional development or sense of self-worth. Risk factors, when we talk about child abuse risk factors for any given family, that we're working with, or even thinking about maybe just people that we know, right? In our communities and in areas in which we work, colleagues perhaps even. Risk factors include parents who have a poor understanding of what children need, and then appropriate child development, and then also their own response patterns, parenting skills, right? So we know that we tend to parent in the way that we were parented. And so there's a cycle that happens in families who experience child abuse, just like there's a cycle that happens in families who experience addiction or mental illness. And that's because of the way that we were raised, right? All of that information was recorded in our own brains for the first 3 years of our lives. And although we don't have specific memory recall of what happened during those years, there's a foundation in our brain, a response pattern that was wired into our brain as very young children during these critical brain development periods of 0 to 3. And so now that we're an adult, even though we don't necessarily remember that, that's how we know how to treat others. And so on a very basic level and a very generic level, that's sort of how we can start to see the pattern of abuse happening in families over time. Additional risk factors include families with substance abuse or mental health issues, and then parental characteristics such as, children, teenagers having babies, right? And just not having as many resources overall, or the information or the access to information and education as someone who, is older. Single parenthood, and so what we see happening here is you have an increase in the stress-related factors, because there's one parent in the home instead of resources of 2 people in the home. And so that can increase the risk factors, and a large number of dependent children and low income. Social isolation and poor social connections also can be a risk factor for child abuse. When we have families where there's a lot of disorganization or a lot of movement, transient families, again, in these situations, what we see happening is a spike in the stress level. And when parents' stress levels are spiked, they're less able to respond appropriately to young children, particularly when young children do something wrong, whether it be on purpose or on accident. And so then we see a response from the parents that's inappropriate and perhaps sometimes abusive to the child. Parenting stress, poor child-parent relationships, and negative interactions between the two also increase risk factors. And then sometimes where we see neighborhood disadvantage is when neighborhoods have high poverty, residential instability, high unemployment rates, community violence, or high density of alcohol outlets also tend to increase risk factors for child abuse, whether that be within the home, within the family, or children being abused by someone, in the neighborhood on a different level, right? So we see it happening in a variety of contexts depending on what's going on in that community. Potential indicators for child abuse. So if you're working directly with children and you're in a situation where you're, observing children or observing parents, and you may suspect that a child is experiencing child abuse, then some of the red flags you will want to keep an eye out for include sudden and severe changes in behavior and school performance. So having an understanding of what's natural and normal in what goes on with children through the lifespan, but then also understanding what's extreme and what truly is a red flag. So when we look at the growth of children in general, a young child through the early childhood development stages acts in a certain way. And then as they move into middle childhood, their brain is growing and developing and they act in another way. And then they move into pre-adolescence and the brain acts in a different way. And then they move into adolescence and it's all falling apart. Some of that is normal. So we know that there are norms within the brain growth and development in the lifespan for any typically developing child. And so you need to have a basic understanding of what those norms are to be able to determine for any given child what may be a red flag. And so we're talking about extreme and sudden changes, right? And not in all cases, but in many cases, you're going to notice something that's just off and that seems to be a little more off than just, this child going through a developmental period. Where the child has not received help for physical or medical problems, even though those medical problems have been brought to the parent's attention. So in that situation, you'll want to consider a couple of things. First of all, the parent's access to getting medical help for the child, is an access issue. But additionally, at some point, if this child is developing infection after infection after infection because this medical problem is not being tended to, then you could be looking at a case of neglect. If the child is always watchful, as though they are preparing for something bad to happen, so perhaps the child operates as if he or she is walking on eggshells all the time, right? Or responds just really severely to situations that don't require such a response. If the child is lacking adult supervision, or if the child is overly compliant, passive, or withdrawn. Or if the child comes to school early or stays late and doesn't want to go home. And so maybe school is the safe haven for the child. That's the only place the child is safe and protected from whatever may be going on, abuse in the home. Then you will want to talk to that child about what may be going on. If the child is reluctant to be around a particular person, right, then that may indicate that this particular person is the person who is abusing the child. And then finally, if the child discloses maltreatment. So we know that almost 100% of children who report that they're being abused are being abused. So I can remember when I worked at the Dallas Children's Advocacy Center in 2004, I was in graduate school and I was interning at the Advocacy Center over the summer. I learned that there were quite a few children receiving services at the Dallas Children's Advocacy Center, females. They were referred there for sexual abuse and that their own mothers did not believe their outcry. And I learned that the mothers, these young girls had outcried that their mother's boyfriend or that their stepfather was abusing them, and that their mothers believed that the child was outcrying and claiming this abuse in an effort to hurt the stepdad or the boyfriend because the child didn't like the dad. And so that the child was using it as a way to sort of get back at the parent, and that was lying about the abuse so that, the child could get that stepfather or that boyfriend in trouble. But what I also learned in the 3 months that I interned there, and we started looking at information and doing some research on child abuse statistics, is that almost 100% of children who outcry are actually being abused. And so it was really hard to continue to work in that space, seeing children who were receiving services for child abuse and who had been identified as being abused by this person in the family. However, their mothers still didn't believe that their outcry was true. So it's a really hard place to be. The parent, if the parent is denying the existence of or blaming the child for the child's problems in school or at home, and again, this is on an extreme level, right? So this isn't just your parent who's holding the child accountable for his or her actions. This is on an extreme level and on the emotional level to where you can see it's impacting the child's health and well-being emotionally or their sense of self-worth. Ask the teacher or other caregivers to use harsh physical discipline if the child misbehaves, and sees the child as entirely bad, worthless, or burdensome. So when I was at Nexus, we had some kids who had heard from their own parents, "I wish you were never born," right? That quote, right? And so in their artwork, sometimes they would draw that, a broken heart, and they would write out, "I wish you were never born," because those were the messages that they had heard growing up. So again, looking at sort of that extremity there for what the child has experienced. If the parent is demanding a level of physical or academic performance that the child cannot achieve. So, for example, if a parent is demanding that a 5-year-old child in kindergarten master fractions, that's going to be an inappropriate expectation. And on the same level, we can think about toddlers who are potty training. A lot of times it's a very high risk time for child abuse because parents lose sight of the fact that the toddler body can't necessarily control all of the functions that are responsible for going to the potty successfully. And so sometimes we forget the appropriate expectations, and parents start to have those inappropriate expectations. So then when the child has an accident, the parent abuses the child because they expect that they should be able to control that. Looks primarily to the child for care, attention, and satisfaction of the parent's emotional needs. Children who are parentified to where they have lost their childhood because they're always having to take care of the family. We see this a lot in families where there's mental illness or substance abuse happening on behalf of the parents, where the children have to kind of take over and get the chores done, the responsibilities taken care of. And sometimes you'll see children as young as 7 or 8 taking care of younger children. And again, they've taken on that role of what the parent should be providing. And if the parent shows little concern for the child, and again, we're looking at an extreme level. So we're not necessarily looking at the mother in the grocery store whose baby is throwing a fit, and or maybe it's a toddler or a preschooler, and the mom's like, okay, come on, we're going, right? And is showing little concern for the child in that moment. We can't necessarily diagnose child abuse on that level, but these are extreme and also patterns that we see. So you've always got to put it within the context of the family and consider what you know about the family, and then also talk to the child to be able to determine, if your suspicion is accurate. And as a matter of fact, in the state of Texas, as mandated reporters, which every adult in the state of Texas is, you don't have to confirm your suspicion before you report child abuse. Suspicion alone is reason enough to call in a report to the child abuse hotline. So it's important to know that, because we'd rather err on the side of caution where you make a report on your suspicion and have it investigated and find out that it's wrong, than just have the suspicion and do nothing about it, and then later find out that the child was being abused. Child abuse protective factors include, for the family, nurturing parenting skills, so engaging parents and families, stable family relationships, household routines and rules, and where parents, monitor children, but then where parents are also educated on typical child development and what to expect from children at different ages and how to relate to children and build that relationship. Parental employment, so when parents have a lower stress because they're not concerned about finances or housing or food, then they have a higher tolerance to be able to respond appropriately to children, even when children act in a way that they expect maybe that they shouldn't, right? So we've got more patience, we've got more compassion, and more of our own cup that's filled up to draw upon to respond to children in an appropriate way. Access to healthcare and social services, and caring adults outside of the family who serve as role models or mentors. So some of the most successful parenting programs around are the parenting programs that create communities for parents by parents. They are not necessarily the parenting programs where all the parents come in and there's a lecturer at the front of the room teaching parenting skills. What works about parenting groups is that the parents in that group create a community for themselves, and they find that they're not isolated. They find understanding in that group. They can relate to the other parents, and they can learn from the peer-to-peer model as opposed to, an expert in the front of the room telling them how and what they should do. And so in a perfect world, we would all live in very safe communities and neighborhoods, and we would be able to go outside to the playground and connect with other parents on the playground. And it would be totally organic and safe and secure, and we would all feel like we have the support that we need. So then when I come home and I'm potty training my toddler and she poops on the floor for the 3rd time today, and I'm stressed out about X, Y, and Z, and I've still got to make dinner or whatever it is, I have my neighbor to call. And my neighbor can say, well, let me tell you what my toddler did today, right? And I don't feel isolated and I don't feel crazy. And so I can take a breath before I respond to my child in a negative way or in an abusive way. But unfortunately, the world isn't perfect and not all of our neighborhoods are set up like that. And we're not all getting outside like that. So not every neighborhood has a safe playground to go to connect with neighbors. We don't walk out our front door and deliver bread and salt and wine to our neighbors anymore. We just don't operate in that way anymore. And so we have to work through specific and structured programs to help parents create these communities. And particularly, we have to work even harder in neighborhoods where there's a lot of community violence. So where we really know parents are not getting outside and getting outside with their parents, with their children to connect with other people in the community. And then community protective factors include communities that support parents and take responsibility for preventing abuse. So where we have programs in the community, we have services, we have opportunities to make these connections, schools that invite families in that are open on the weekends, that are open in the evenings, parents who actually attend, right? All of these things strengthen our communities. And if we take responsibility for preventing abuse by sharing this information and then by providing programs that help to relieve the stress for parents, whether that's a parenting program to relieve the skills the parents have, or whether that's an employment fair, a job employment fair, or a housing application assistance to help relieve the stress in any way that's appropriate for that adult stress, because that strengthens their response to children. And the final topic that we're looking at today is shaken baby syndrome. The risk factor, so shaken baby syndrome, once again, is the violent shaking of a baby, an infant or a toddler, and it usually, usually the caregiver is holding the baby by their shoulders, typically, and shaking that child back and forth so violently that the head is rocking back and forth. So you can think about it's very rapid and it's very violent. So you could think about the baby's chin would be dropping down and hitting their chest. And then when they're rocked backwards, the back of their head would be hitting their spine. So that's how violently the head is shaking back and forth. And the baby is being shaken to such an extreme measure that it causes brain damage, because shaken baby syndrome is brain damage. It causes damage in the brain, and that damage in the brain cannot be repaired or corrected. It's brain damage and it's lifelong and it's permanent. And in many cases also, shaken baby syndrome is fatal, depending on how severe the baby was shaken. So once again, it doesn't happen by bouncing a baby on your knee or playing with the baby, kind of tossing them up in the air just a couple of inches, right? A baby does not get brain damage from that. Shaken baby syndrome also does not happen from a baby rolling off of a bed either. So again, it's a violent shaking, right? It's not caused by bumping into, toddlers are cruising around and they fall down and bump their head. Now they could still experience an injury from bumping their head, depending on how hard it bumped on that area that it bumped, but it's not the same as shaken baby syndrome. With shaken baby syndrome, you're going to see brain damage in the front of the brain and the back of the brain, because the baby was being shaken back and forth violently, and the brain was literally kind of knocking on both sides of the skull there. And so you see damage in a variety of areas, as opposed to what you might see if a baby just fell and bumped their head in one area. The risk factors for shaken baby syndrome include, on behalf of parents, unrealistic expectations of babies. Young or single parenthood can be a higher risk factor, again, if the parent is experiencing a lot of stress and has a poorer response to a baby who's been crying for a long time in the evening. A parent may pick up the child and just start to shake them, thinking that this may cause them to stop crying. Stress, high parental stress is a higher risk factor for parents becoming frustrated and shaking a baby. Domestic violence in the home. A parent who's under the influence of substances may become more violent and pick up a baby and shake them. Unstable family situations can be a higher risk factor, parental depression, or a history of mistreatment as a child. The signs and symptoms of shaken baby syndrome include extreme fussiness or irritability on behalf of the baby, or difficulty staying awake. So you can think about if you've ever been around a child who had a concussion or a person who had a concussion, it's sort of some of the same indicators that you think about: breathing problems, poor eating or vomiting, pale or bluish skin. If a baby all of a sudden develops seizures and there's sort of an unexplained reason for it, and you also suspect child abuse, it could be that that child has been shaken. Or if there's an immediate paralysis, or if a baby's in a coma, then you would start to consider shaken baby syndrome. And medical experts will certainly start to look into x-rays and whatever sort of brain scan monitoring that they can do to determine what's going on with the brain if they see these severe changes. When we look at prevention for shaken baby syndrome, parent education is very, very helpful to help parents understand the dangers of violent shaking. I can remember when I did parent groups and we would talk about shaken baby syndrome, so many parents would ask me and become really concerned. Oh my gosh, I was bouncing my baby. I was playing with them the other day, and now I'm worried that they have brain damage. And again, it's not that. This is violent shaking. You would know it if you saw it. It is violent and aggressive shaking, and the parent is in distress and they're angry. So you can't miss it if you were to see it happening in action. Provide tips to soothe the crying baby and manage stress. And so educating parents about the things such as the period of purple crying, that, babies within the 4th trimester, which is the first 3 months of life, their bodies are still immature. They're not fully and completely developed when they're born. And so there's a lot of growth still happening. And so, sometimes we talk about colic, and sometimes people understand that, or sometimes the period of purple crying, or just helping parents understand that by the time your child is a couple of months older than now, whether that be 4 months, 6 months, 9 months, the baby will not be crying all night, every night for the rest of his life. That's not going to be the case. So if you can just get through the next however long it is until this baby does develop that routine, and then providing the strategies that help parents with that. So Dr. Harvey Karp has a wonderful video about the 5 S's, and it's called The Happiest Baby on the Block. And all 5 S's you can access through YouTube for public viewing, and they're just short little clips. You can buy the entire video, but you can also find these short clips on YouTube that show the 5 S's. They're independent little pieces of video clips, but you've got one for the first S and the second S and the third S. And so it's like shushing, like providing some noise in the environment. So, running a vacuum cleaner or a hair dryer or a sound machine, those are the safest things to do these days because they make those now. But just a general hum in the background is one thing that can calm babies. Swaddling is another. Sucking, so the pacifier. Swinging, putting babies in a swing when they've got all this alert and all this movement is helpful. And then finally, holding them on their side, but not while they're sleeping. So we don't want to put them to sleep on their side because that's against the SIDS recommendation, but there's this sort of side football hold where you kind of jiggle the baby. That Dr. Harvey Karp has this strategy, and he says that it creates sort of a reflexive response in the baby to stop crying. It calms them down. Counseling for parents who may have difficulty managing emotions, and an awareness of new parents within the family and the community who may need support, right? So campaigns are helpful. The Back to Sleep campaign is a SIDS prevention effort campaign. And so shaken baby syndrome campaigns could provide the same information with strategies for helping to calm a baby, or even if your baby will not calm down, just validating the parent and saying, dealing with a crying baby is frustrating. Yes, absolutely. Especially when it's at the end of the day and that high time, and you're already tired because you just got home from work and the baby's crying from 3 to 7 p.m. because that's sort of like the circadian rhythm of when babies cry the most, especially if they're in this colicky stage, period of purple crying, however you want to call it, and that it does not last forever, but that it is frustrating, and infant crying is normal and it will pass. And so giving parents a strategy of, okay, you've tried all 5 S's, nothing works, you're spent, you're done, you're worried you might shake your baby, or you're just tired and extremely whipped, right? And you cannot think of anything else to do, then put the baby in the crib with the fitted sheet only, down on their back, and step out of the room, right? So telling parents that sometimes it comes down to that being the safest thing that you can do. The baby is not going to hurt himself while laying in a crib. He cannot thrash himself around enough to cause his own brain damage. So even if you have to do that and step out for a few minutes to take a breather, to recharge yourself, to be able to respond appropriately, then that is a better choice than continuing to try to hold this baby if you feel like you're getting to that point to where you're going to have an aggressive response. And being sensitive and supportive when parents are trying to calm a baby. I can remember clients telling me when we were at Nexus that, they would go to the hospital and deliver their baby, and their mom would come to visit them, and the baby would be really fussy and irritable, and the mom would just pick up the baby and immediately calm down the baby. And two things happened in that moment. The mother felt completely inadequate and ill-equipped to parent, and why can my mom do this, but I can't do this? But then also there's a missed opportunity for the mother to learn how to do that with her own baby. And so sometimes when we swoop in to help, we can also provide a moment for the mom to try to do that herself as we sort of talk her through it or tell her what we would do, or show her how we did something, right, so that she can gain her own confidence. So for the last couple of minutes here, I want to get your thoughts on how you can share this information today and things that you can do with families, how you can help them understand prevention about sudden infant death syndrome, shaken baby syndrome, and child abuse, and what it means to you to think about these topics and looking at prevention, how to strengthen our communities, helping maybe not just families, but your own colleagues. So I'm going to give you guys a couple of minutes to type in. You can all chime in at once if you want. And I'm going to go on mute, and I'll read some responses in just. Okay, I see a couple of responses here. Yes, so I will share the slides in the follow-up email for those of you who are asking for the slide deck. So I'll send those out for your reference. And so Marcia says your agency provides individual parent coaching, so sharing individually with parents as needs arise. Yeah, absolutely. And if you have any questions or are looking for anything that's sort of maybe a little more parent friendly, not that this isn't parent friendly. I think our talk today would be perfectly appropriate for parents, but there's a lot of popular media out and some things that are really great that you could find on YouTube and around. 0 to 3 has a lot of pamphlets and brochures and things on this topic that you could also share with parents sort of as a takeaway. So that's one thought, but let us know if we can help you with any of that as well. Elizabeth, you can share it with your families through parent education meetings. Wonderful. And one thing to think about, Elizabeth, if you're working with parents in groups, I know that I always encountered sometimes that this would become maybe a trigger topic for some parents. Sometimes I would find out that a parent had a little brother who died of SIDS. So maybe they didn't have their own child die of SIDS, because I probably would have known that before the parenting group. But they had someone else in their family. And so sometimes things would come up in there that I would just want to be mindful of as we're talking about these, and let parents know that you're talking about some sensitive things. And so let's see the next one. Sue, exploring cultural differences in families outside of the U.S. and explaining data. Yeah, absolutely. And Sue, I'm glad you brought that up. So one of the things that Dr. Wendy Middlemiss shares, and I think this is a great point. We heard this from her last January on our Safe Sleep webinar, and I'm sure she'll talk a little bit more about it this month on Thursday with the expert webinar, is that in some cultures, co-sleeping is the practice. And sometimes people from with those values live right here in our communities, and we're working with them. And so what we want to do is provide the data regarding safe sleep, but that doesn't mean they're going to choose to not co-sleep, right? So they may still say, well, I'm co-sleeping with my baby. And so the point isn't to change their mind and say, but no, you can't co-sleep, right? And have them come around to what we're saying the recommendation is. The point is to provide the education and then meet them where they are. And so if the parents say, well, I'm co-sleeping with my baby because that's a value that I believe in and it's something that I understand and it just makes sense to me, then we can say, okay, well, here's what the data shows and here's what safe sleep recommendation is. So because you're going to go sleep, how can we create the safest sleep environment in your co-sleeping environment? And so you're still respecting and honoring the cultural difference, if it is a cultural difference or whatever's going on there. The parent's going to do what they want to do. And then helping them understand what we know through the data and what we know the recommendations are. So they're educated on it, and then meeting them where they are and saying, where can we find that safest space within the context of what you want to do? Catherine, you say an excellent resource to help parents feel more relaxed about handling their babies and encourage play. Also vital information regarding safe sleep to give parents peace of mind so they can get much needed sleep while baby is napping. Absolutely, lots to talk about there. Holly, we can begin conversations in task force meetings locally. Absolutely. Holly, I'll mention too. So I've seen over the years, I've seen a lot of campaigns on back to sleep. And I haven't seen as many public service advertisements about shaken baby syndrome, probably because it is a little more taboo because it is child abuse, right? And so I can see the difference in why we may not see as many campaigns for shaken baby syndrome. But it could be something that we need to really look at our systems too as we look at prevention. Smithu, parenting groups, being able to talk with parents who may be concerned about similar issues. Absolutely. Molly Ann, you provide training for parents and caregivers, including childcare workers. Yes. So yes, absolutely. Frequently requesting that topic. And as a matter of fact, childcare providers are required to have these training in these topics annually. And so I'm glad that you can bring this information into those workshops. And it is also important to recognize that childcare providers are also just as much responsible for SIDS prevention, shaken baby prevention, and child abuse prevention. So I was referring a lot to parents today in this webinar, but really any caregiver, needs to know this information. Michelle, you have what you call our school a socialization, which is where you invite parents to come and hear about a certain topic. Wonderful. So you've got a platform there to provide that information. And Elizabeth, you provide baby bags to some families who have newborns and are pregnant. And you can, oh yeah, great, wonderful. Yes, so there are a lot of pamphlets and flyers. I would start with 0 to 3 as you look into some of that. And if you're having trouble finding anything, shoot us an email and we'll send you out to our clearinghouse of references for this. And Michelle, you also have home visitors, so you can talk to the parent one-on-one. That's a great place too. Maybe a little easier to speak to a parent one-on-one in a home visit than in a group, depending on the parent's situation. Same thing with you, Ileana. Wonderful feedback. Thank you, everyone, for engaging here as we wrapped up. Forming relationships with family from Angela in our program, active listening and giving support and feedback. Sure, absolutely. We always have to meet parents where they are, especially if we're looking for any sort of change in behavior. We've got to validate where they are first and make sure they feel safe and secure in their relationship with us. Yes, Suzanne, I will, again, I'll send these slides out in the follow-up email shortly. All right, good. So we're 3 minutes over, so I'm going to go ahead and log off. I will be sending the follow-up email in just the next 20 minutes. Look for that. It will have your survey link. We are completely digital again in 2018, and so you'll complete your survey. At the end of your survey, when you hit submit, it will take you to your CEU link. And then in the body of the email, I'll attach these slides, and then in the body of the email, I'll also include the video links to both of the videos so that you can share them with your families. Thanks so much. I'll stay on for another couple of minutes if anybody has any questions. Look for that follow-up email soon. Have a wonderful afternoon. Thanks for